The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
This time last year, the Omicron variant was just getting started. Tonight, what public health expects this winter from COVID amid an early cold and flu season. Then, our Ontario hubs explain why a recent blood drive in Brampton did more than attract new donors. And from Canadian foreign policy to COVID's effect on immunity, we've got the agendas we can review. It's Friday, November 18th, and that's all ahead on the agenda. Earlier this week, Ontario's Chief Medical Officer of Health strongly recommended people wear masks in all indoor public settings. It's not what anyone wanted to hear. Is it a worrisome sign of a tough winter ahead? Let's find out from Dr. Mustafa Hirji, Acting Medical Officer of Health for Niagara Region, who joins us tonight from Thorold, Ontario. Hi, Dr. Hirji. It's nice to see you again.
Hi, Desnan. Nice being on again.
It's been a really heavy week in the province. It just seems as if there's a lot of things happening when it comes to our health. What can Ontarians expect from COVID-19 this fall and winter?
Yeah, it's always a bit difficult to try to stare into the crystal ball because none of us has a great view of the future. And we're in a little bit of uncharted territory with a first season where we have COVID plus flu plus other viruses going around. We also, unfortunately, don't right now have any kind of modeling similar to the modeling we used to get from the Ontario Science Table. But, the best guesses I can say is really looking at what we've seen in past winters is that as we get deeper into winter, unfortunately, infections start to get worse. And that was even true the last couple of winters when we're dealing with COVID-19, where unfortunately in both the past Decembers, we ended up going into lockdowns with really crushing waves of COVID-19. And that's just because I think the fundamental environment of winter makes it more hospitable to these viruses spreading. It's colder, we all move indoors, we are approaching the holidays, we start having holiday gatherings, and that gives an environment where the virus is just able to spread more. On top of that, just background, we have a situation right now where there's fairly low vaccine uptake in Ontario. People have gotten those first 2 doses in great numbers, but in terms of a fall booster, it's about 15% of our population right now has that fall booster. So there's a lot of people who don't have the additional protection that we've been recommending for this fall. And of course, then on the topic of masks, I don't think we've really seen many people wearing masks anymore. That's really eroded since the mandates went away. And at least, from my perspective over the last few days, I have not really seen that uptick very, very much with the recommendation for masking. And then lastly, we, of course, have always the potential that a new variant could arise. So my sincere worry is that, more likely than not, things are going to get worse now before they get better in terms of respiratory viruses. And I think it's why we want to take some measures to make sure we're better protected in the near term, and then some real long-term measures so we can better have control of this for the long term.
You brought up a lot of things that I'd like to have a few follow-ups on. You mentioned that we don't really have data right now, and I think people may be under the impression that because the mandates are gone, we had a nice summer, people might not be aware of how much COVID is in our communities, or that COVID is still something that we should be really concerned with. You mentioned a variant, or do we know, is there a dominant variant right now?
Yeah, so, you mentioned we had a pretty good summer, and I'd say it's relatively good, but, here in Niagara, our August actually had the most deaths from COVID-19 since February of 2021, which is, of course, before we were doing mass vaccination. So definitely it wasn't that good, unfortunately. We did see a couple of waves over the summer, and we did sadly see a lot of people pass away due to COVID-19. In terms of the variants going around, it's really become a plethora of many different variants that are spreading. The main variant still seems to be the BA.5 variant, which was the one that we were seeing in the latter part of the summer. But as opposed to being, 80–90% of our infections, it's closer to maybe 50%. And we've been seeing this family of variants called the BQ variants, the BQ dots, various different numbers. They seem to have risen quite quickly over the last month. They've gone from about 5% to closer to about 30% of the variants that we're seeing going around. And what's worrying about them is that there's some evidence that these variants, that the past immunity we have from COVID-19 isn't going to protect us as well against these variants. It looks like, of course, the protection against hospitalizations, that's going to remain pretty good, but it's not going to remain as good as it was before. We don't know a lot yet, I think. We're still learning a bit more about these variants, but that does give me a little bit of caution that things could get a little bit worse in the next few months because of these COVID variants.
You mentioned how Niagara had the most deaths in August. I can't even imagine how that's impacted people in that community. And I think that would be a very surprising thing for a lot of us to hear. You mentioned that hospitalizations and deaths might not be as bad. Are you concerned because with the level of people getting updated on their vaccines, are you concerned that this winter might see more people ending up in the hospital dying?
I think that's absolutely the possibility. And I think the primary driver would be, as I talked about, the winter period is going to be a time when it's easier for these viruses to spread. More people are going to get infected. So that fraction of people who unfortunately end up with severe disease in a hospital or worst of all pass away is going to be a larger group. And then if we get new variants, that of course, throws another wrench in the works, which could potentially make things worse. Just to quickly speak on the topic of hospitalizations and deaths, I don't think, we should, ignore the fact that things are a lot better than they used to be. We are not seeing people hospitalized or passing away from COVID-19 at nearly the same rate as they used to be. We've made a lot of progress, and that's principally thanks to the fact that over 90% of Canadian adults have gotten vaccinated, and they have that protection. But the flip side is also true that we haven't completely gotten rid of COVID-19 as a problem. Here in Ontario, we're seeing approximately, I think, about 1,500 people on any day who are currently in the hospital. So not necessarily new hospitalizations, but a total census of people hospitalized is about 1,500 people a day. So 1,500 hospital beds a day are occupied by people with COVID-19. And we're seeing about 16 to 17 people every day passing away from COVID-19, which is up from about 6 weeks ago when it was closer to 9 or 10 people. So definitely it has gotten worse. And what's I think most disappointing to me is that when I look at the number of deaths we've had in Ontario, in each year of the pandemic, in 2020, we had a little over 4,400 deaths. In 2021, a little over 5,300 deaths, so a worse year. So far in 2022, we have just under 5,300, and last year we had a little over 5,300. And probably within the next week or so, we're going to eclipse last year's total so that 2022 will have been the most deadly year of this pandemic so far. COVID-19 is a number 3 cause of death in Canada. It is, I think, it's still a serious problem, definitely a problem that's not as bad as it used to be, but one I don't think we should be ignoring. And we need to take both some short-term measures to make sure this fall and winter isn't as bad as it could be, as well as some longer-term measures so we can make sure that future falls and winters aren't going to be as bad.
We still have about 6 weeks left of this year, so we'll be watching that number. You mentioned vaccines. We have the bivalent vaccine. What's the uptake been like for that?
Yeah, so I talked about the fall booster dose, and that's probably pretty much on par with what the bivalent vaccine is, because the bivalent vaccine came out, I think, the second week of September. So really, all the vaccines we've given over the fall have been the bivalent vaccine, except for children under 18. And so it's probably around 15% of people have gotten it. So it's definitely not nearly as high as I think we would like to see it. So I think there's probably a few reasons for that. And, obviously, I'm, speculating a little bit here. Polling that would be done could probably get a more accurate reason why. But I think first off is a lot of the urgency to get vaccination is lost. I think back in 2021, there's a huge urgency to get vaccinated to hopefully get out of the pandemic. And it absolutely made this pandemic much less serious, which is why our society has been able to reopen. We've returned to a large degree back to normal. But it didn't completely solve the problem, and we do need to keep getting these booster doses. Second thing I think has been a challenge is that there's been misinformation, I think, floating around, and I think it's gotten louder over the last year. And so I think some people who are maybe more on the fence of getting vaccines are hearing more misinformation. It's giving them a bit more pause. I think some people are also perhaps suffering from a little, missed expectations. They thought that when they got those 2 doses, things would be better, and then it wasn't better, and we keep recommending booster doses, and that's maybe giving them reason that they're confused, and unfortunately that gives an opportunity for the misinformation to feed in. But the one other thing I'd highlight is that I don't think we've had the strong promotion of this vaccine anymore. I haven't really seen the big campaigns by the federal government or the provincial government. I haven't seen the radio ads, the TV ads, the mail-outs that went to everybody's home from the federal government. really pushing people and encouraging us to go out and get that bivalent dose. And I think that's a big reason why we haven't seen as good uptake. And we really need to sell this dose and the importance of getting it.
Well, you mentioned confusion. I think some people might be confused. I'm confused, and we've been covering this for the past 3 years now. So help us clear up that confusion. If you've never had a COVID vaccine and you're considering getting it, can you get the bivalent vaccine? When do you get the bivalent vaccine? And do you get a flu shot? Or can you clear that up for us?
For sure. So the first 2 doses of vaccine you get are going to be the old version of the vaccine. The bivalent vaccine isn't good for a booster dose, so after your first 2 doses, but the first 2 doses are a previous version. Absolutely recommend, if you have not yet gotten those 2 doses and you're thinking about it, it's never too late to make that decision to go get that vaccine. Absolutely go get it. It cuts your risk of being hospitalized, having a severe outcome by about a factor of 9. So it's much, much safer to have those 2 doses of vaccine. If you've had, no matter how many doses you've had so far, everybody who's had 2 doses can get a booster dose this fall. If you've had no booster doses, 1, 2, 3, doesn't matter. Everybody's eligible for a fall booster dose. So if you're age 12 and up, come out, get that fall booster dose so you can have the best protection going forward for the rest of this fall-winter season. For children who are age 5 to 11, if they've had their 2 doses, they can also get a booster dose after 6 months. So strongly recommend they do that if it's been 6 months since they had their second dose. And then for children who are the youngest age group, 6 months up to 4 years of age, they're also eligible to get 2 doses of vaccine. So very much recommend they go out, get that protection, and make sure they're safe. I think we've all heard the stories about the hospitalizations of children over the last couple of weeks. Really, really sad stories about children who are struggling to breathe. And I can't imagine how anguishing that must be for the families who have a child like that. Let's make sure COVID is not going to be a cause that causes some children to be hospitalized, to make sure they have that vaccine so they're protected.
We also know that the flu season started earlier this year. So how do you make the determination if you need a COVID booster versus getting a flu shot? How do you make that decision?
Yeah, the great thing is that it's not actually a decision to make. You can go out and get both of those. If you're getting your first couple doses of COVID vaccine, you can get your flu shot at the same time. If you're getting a booster dose of the COVID vaccine, you can get your flu shot at the same time. Go out, get both of them in the same visit, and make sure you get the protection from both right away.
But what if you've had COVID recently? Can you get the bivalent and the flu shot?
You can get it.
When?
Yeah, so as soon as you're out of isolation, you can actually get your COVID vaccine right away. It's generally advised that that's not the best time to get it because your immune system is already just revved up to fight off COVID-19, so you've got a bit of immunity from that. So the recommendation is really wait about 3 months, and that's when you're going to get the best benefit for getting that booster shot. So if you've had COVID recently, wait about 3 months, then go out and get that booster shot, but still go out and get your influenza shot so you have that protection right away.
Some health authorities, you mentioned children. Some health authorities say that everyone 12 and older should get the bivalent shot at least 2 months after their last vaccine dose. Others say between 3 to 6 months is the ideal time. What do you think?
Yeah, the National Advisory Committee on Immunizations has our best experts in terms of vaccinations in Canada, and their advice has really been to get it in the 3 to 6 month period. So that's really what I recommend. There's a little bit of a range there, and I think it's really a trade-off of, do you want that protection earlier and then you go closer to 3 months, or do you want to have the kind of longest, strongest, long-lasting protection where you go closer to 6 months? Thinking about, just how we're likely going to get a, spike of COVID-19 when we go into December and January, just looking at the fact that it happened the last 2 years and we went into lockdown in December the last 2 years. Well, I'm not expecting lockdown. I am expecting probably there will be a surge. So I suggest that if you're past the 3 months point, get that vaccine in December so you have the protection going into that most dangerous period in December and January.
You mentioned a surge earlier this week. Health Minister Sylvia Jones said that this week, while cases of flu and RSV are still going up, the pace has slowed. Does this give us hope that we're coming to a plateau?
It's certainly, I think, a reason to maybe be hopeful, but I think it's always dangerous to put too much stock into hope. Seeing a plateauing 1 week doesn't necessarily tell us there's a trend over multiple weeks, and it's, kind of trying to guess what's going to happen in the future. And again, we don't have any crystal balls. It's, I think, certainly something I'm hoping so that we can see some relief for our hospitals, and especially for the children who've, I think, been particularly hard hit by the recent infections. But the best thing we can do to help turn that hope into reality is do the things that are going to keep us safe and limit the spread of the virus, which means getting that COVID booster, that flu shot, so we have that protection, making sure we're wearing masks in indoor spaces so that we're limiting the ability of the virus to spread, and making sure that we stay home when we're sick so we're not spreading that infection out to anybody else. And that, I think, is how we can help make sure that hope turns into reality.
Well, we're hearing from more and more experts that we're likely seeing a double or triple cohort effect, that an immunity gap, post-COVID immune dysregulation, and higher circulation of respiratory viruses are contributing to the surge in illnesses. What do you think is going on?
Yeah, so I think you've raised a few different topics there, and I'll break this down a little bit. Ultimately, I don't think we know for sure what's happening, and it could well actually be a combination of various different factors. One of the things you mentioned is this idea of an immunity gap, or some people call it an immunity debt. And this is the idea that because we've done so much over the last 2 years that protected people from infection, maybe our immune systems aren't as ready now to face other infections this year. So that's why perhaps children are being hospitalized in greater numbers than usual, because the infections are hitting them harder. I don't think that really makes a lot of sense. This is a very novel theory. There's not a lot of evidence, or really any evidence, I think, yet to back it up. But our bodies are consistently exposed to bacteria all around us. And we saw other viruses still spread over the last couple of years. So our immune systems are always active. I really don't think that this immunity debt idea really makes a lot of sense. So I think it's really doubtful that that's what's behind what's happening here. The double, triple cohort effect is the idea that because the last couple seasons we stopped so many infections, there's people who didn't get the immunity from having, say, something like RSV. And so now there's a larger group of people who've never been exposed to RSV, and so we're going to see more people infected this year than usual. That is something that we have seen happen in reality. But what we actually saw with RSV is that while 2 winters ago we pretty much suppressed RSV and it wasn't around, last year RSV did spread, and we actually had a twice as large wave than usual, which kind of fits that twice as many people got infected because we skipped 1 year of people getting infected, so we all caught up with that. And so because we had that larger wave of RSV, I don't think it really explains why more people are getting severely ill this year, particularly more children getting severely ill. The other thing I'll note is that the people who would get RSV would usually be our youngest children. Once children are about 2 years of age, they've been infected with RSV. So we'd be thinking it'd be 3-year-olds, 4-year-olds who'd have missed getting infected the last couple of years, who might be more susceptible and more likely to get it this year. But we've seen the hospitalization trends, even for children aged 5 to 17, go up quite drastically over the last few weeks. So I do think there's something else going on beyond just this idea of the cohort effect. The final one you mentioned is immune dysregulation. And this is something we've seen with some viruses, that some viruses, after they infect us, they actually cause some haywire and some weakness to our immune system. So for the next several weeks or several months, any other infection that comes along is going to be more severe for us. We've seen this, for example, with measles, and we've seen it actually with COVID-19 as well. Don't know if this is what's happening, but it's certainly a plausible theory that children who had COVID-19 in the last few months, their immune systems are weakened. So when they're getting RSV this fall, it's unfortunately more severe for them. And that's why maybe some of them are being hospitalized in greater numbers. Likewise, influenza is more severe. And that's why we're seeing more emergency department visits and hospitalizations from it. Again, I don't think we have any hard data showing that this is the case, but it's definitely a worrying possibility. And I think that's why we want to take some action right now to make sure we mitigate any impact of that causing people to get severely ill. So again, masks, vaccines, staying home with sick are what are going to help us through the next little while. And then we need to really think about some longer term adaptations to make sure our society is just generally more resistant to these viruses long term.
So far, we only have Paxlovid to treat COVID. How does it help, and who should have access to it?
Yeah, so Paxlovid is a medication that can treat people who are infected with COVID-19. It's a great medication for people who are particularly at high risk of hospitalizations. It quite substantially reduces the risk of being hospitalized by like 80 or 90%. The people who should get it are the people who are highest risk of having those severe outcomes, such as hospitalization. So that's generally people who are older, people with underlying medical conditions, and people who haven't made that good choice to get vaccination and don't have that protection from vaccines. What I'd really recommend is if you're in one of these groups, talk to your doctor about Paxlovid, make sure you understand the process to get it, because once you do get COVID-19, there's only a few days where you're able to get it. You need to start that medication right away for it to have benefit. So if you can figure out what the process is, the lab testing and other things you're going to need to get done, that'll make sure that you have no resistance on the way to getting it. So I would really recommend people speak to their doctor about it if they're in one of those groups who is elderly, has underlying medical conditions, etc.
Well, you mentioned action. This past Monday, Dr. Moore very strongly recommended a return to indoor masking. He stopped short of a mandate. What needs to happen to protect kids and to prevent the future collapse of our healthcare system?
Yeah, so I think absolutely the recommendation to wear masks is a good one. It's one I've definitely been articulating here in Niagara for a while.
Do we need a
Masks,
mandate?
my thought is we probably do. As I mentioned, the last few days, I've not really seen more people wearing masks. And I don't think that's actually because people don't believe in masks. I think it's actually more to do with the psychology that we are human beings, that we're just hardwired to conform to the people around us. And if other people aren't wearing masks, it's really hard to be the only person in the room wearing a mask. And, I say this from experience because often I am the only person in a room wearing a mask. And what we saw back in 2020 is that while we had a recommendation for wearing masks, it wasn't a lot of people who were wearing it. When we went to mandates, people pretty much all of a sudden voluntarily all started to wear masks. There wasn't much enforcement to make it happen. People just started to do it because it made the social norm. And so I think for a short period of time, we do need a temporary mandate to once again create that social norm so that kids and everybody else in our society is protected from the severe outcomes from these viral illnesses. But I also just want to emphasize that we're not just looking at the short term, that we also think about the long term and long-term adaptations our society needs to do in terms of ventilation, filtration, paid sick days, and other things that can make us safe from these viruses long-term.
Dr. Hirji, thank you so much for this. We really appreciate your time and insights. Thank you.
You're very welcome.
A collaboration between Canadian Blood Services and the volunteer-run Sick Nation recently turned 200 people into new donors. Vicky Mochama is TVO's new diversity journalist, and she went out to find why such clinics matter. Welcome.
Thank you.
All right, so Sick Nation and Canadian Blood Services have teamed up for many years, but lately there's been a notable increase in people giving blood. Tell us the story behind that.
So Canadian Blood Services overall has had challenges with getting people to donate blood over the course of the pandemic. They have something like a 31,000 person shortfall. But there are these pockets where people are really interested in donating blood, and Sick Nation's efforts is one of those. So you see the Sick community turning out in droves to donate blood. So at the blood drive in Brampton that I went to, they filled up all their slots, and whoever was deferred was then given an appointment to donate plasma or stem cells or something else. But they really, their events, they turn out people and they get blood donations that they're looking for.
All right. I'm not asking you to be a hematologist here, but in your article you did speak to one. Break it down for me, the basics of blood types.
Think of your blood cell, your red blood cell, as a saucer. And on the saucer, there sits these little elements on the edge of each one. Some of them are antigens, some of them are proteins. The antigens are what define your blood type. So you have A, AB, B, and O. And then there's proteins called the Rh factor, the rhesus factor, that also sit on your blood type that gives you Rh negative or Rh positive, and that's an inherited trait in your blood. But there are also other antigens or proteins that sit on that blood cell, around that saucer, that shape what blood really is. So blood in general doesn't see race, but blood is geographically constructed, which is really interesting. So people who are from China are more likely to be O positive or O negative and have different proteins in their blood and different antigens in their blood cells. And so it's an interesting question of how blood cells can become racially constructed or racial ideas.
Very interesting. Now that we know that, why is specialized blood matching important?
Specialized blood matching can be really, really important for people who have rare blood disorders or rare blood in general. So some people have just rare blood, and if you're going to get a blood transfusion, you need blood that matches up with yours or that one that your body will accept. Because if you think about it, you're already sick, and if you get the wrong type of blood, your body is now fighting something else in addition to what you're already dealing with. And so this can be a huge concern for diseases like thalassemia or sickle cell disease, where those blood types need specific blood. If you have sickle cell, for example, you're probably getting on average 20 to 25 blood transfusions per year. So you need very specific blood to be given to you.
All right, so people who have donated probably know that they have to go through a number of questions and questionnaires, and it sometimes takes longer to fill out those questions than to actually donate blood. I'm hoping you can break this down. What are some medical barriers to blood donation?
There's the obvious ones. Health is a big one. Is it good for you specifically to donate blood? For some people, if they donate blood, they might lack iron, and that might lead to them fainting. So they might be turned away for being anemic. Age is a big factor. You have to be over the age of 17. You can't have alcohol in your bloodstream. These are things that are fairly standard, but there's a big long list of them. Those are some of the barriers to donating blood. But there are also other barriers that are more geographic or rule-based according to Canadian Blood Services' own eligibility rules. So if you've ever had malaria, you receive a lifetime deferral. And a deferral is basically what Canadian Blood Services means when they say, we'll never take your blood. And this is, becomes a problem for people who are from places in Africa where they've gotten malaria. Now, malaria doesn't necessarily stay in the blood for your entire lifetime, but according to Canadian Blood Services rules, if you've ever had malaria, you cannot donate blood.
That's it.
That's it.
Okay, so not everyone has, let's talk about access to blood clinics. That's another part that you talk about in your story. How is that barrier being overcome right now?
Well, Canadian Blood Services is obviously doing its best efforts to find partners like Sick Nation who can get them deep within the community and get them to places where people need. But I also talked to a truck driver at the blood drive who said that he donates blood, but his staff that work at his trucking company can't necessarily make it out to the blood drives, even if they happen on weekends, because they are driving all day, every single day of the week. And so one of the challenges is really getting the blood clinics to where people are at. And so it's an ongoing question of how do you get the most diverse blood pool possible in a really challenging time where people have different schedules and different needs.
All right, so the blood drives in November organized by Sick Nation actually marks a specific memory. What is that?
It's the 1984 Sikh genocide, and it's a massacre that happened across India after the assassination of Indira Gandhi, and Sikh people were effectively blamed for the assassination. And so thousands of Sikh people died. And as I spoke to one of the organizers, for him it really comes full circle to be organizing a blood drive, because he feels that Sikh people's blood was shed, and as a result, the best that they can do to raise awareness of the genocide is to then give back blood. And for him, he says it's squarely within his Sikh values and his Canadian values.
Last question to you. Of course, there's about 15 of these drives being planned for this month. Where can we find more information on where people can actually go donate blood?
You can go to the Canadian Blood Services website, and there's lots of locations. Some of them are permanent, some of them are temporary. There's lots of places to donate blood. But if you want to see what it's like with the Sick Nation drive, they have their own website, and you can go to the Sick Nation, and they have blood drives across the country as well, so that if you're not necessarily in Ontario, you can donate blood across the country.
All right, Vicki, thank you so much for joining us on the program.
Thank you.
The agenda this week considered new directions in Canada's foreign policy, assessed the capacity of Canadian intelligence services, learned how memories are made, and spoke to author and physician Dr. Gabor Mate about our collective health. The agenda's Week in Review begins, examining immunity after COVID-19.
Has the idea of immunity debt been misunderstood, and can you help explain what that actually means?
Well, I'm not actually sure what it means when people talk about immunity debt. It's not a term I would use. Really, a piece of this issue, at least, is the fact that we didn't expose children to RSV for a full two winter seasons during the pandemic. So usually in temperate climates in Canada, in the winter season, you get RSV. It starts in October, it goes up to a peak in November, it's stable over the winter, starts to come down in March and go back in April again, and it's pretty reliable. But we've had 2 years with no RSV activity. So there's no question that we now have a cohort of susceptible children who, of ages that pre-pandemic would not be susceptible. It's actually been pretty quiet in pediatric ICUs, with the exception of COVID activity for the last 2 years. And that group of children is now getting RSV infection for the first time. And in Canada, we just don't have much spare capacity in any of our ICUs, but particularly in our pediatric ICUs. So the increase in the number of kids who require hospitalization just because of the increase in the number of kids who are being exposed to RSV for the first time is incredibly difficult for our system to deal with. You're not hearing so much about it in other countries because other countries don't have this really, really tight number of intensive care unit beds that we have in Canada. But there's no question in my mind that the biggest impact of this excess in illness in kids and in our ICUs is related to the fact that kids just weren't exposed to RSV. And in the end, all children are going to get exposed to RSV. The fact that we didn't expose them to RSV during the pandemic is a little bit neither here nor there. The problem is not so much that they're getting RSV, although I will say there's a whole bunch of new RSV vaccines that are going to be on the market for kids in about 2 years. And when we get those vaccines, we won't have this illness and it will be awesome. Okay, but we're not quite there yet. So in the meantime, we can't prevent kids from getting RSV. And our problem is not so much that these kids are getting RSV. It's that these kids are getting RSV all at the same time, which is incredibly difficult for their management in our pediatric ICUs.
Colin, I'm going to bring you in here. Is there any validity, and I'm going to, for the sake of this conversation, call it maybe immunity gap theory, opposed to the immunity debt, but is there any validity to this and to what Alison is saying?
Well, I agree with Alison, and I've learned when I disagree with her, I'm usually wrong. But I'll depart on it a little bit because I think both are going on. There's no question that there's this double cohort effect. That's true. But we did have a spike in RSV in the spring, and we have very low levels now. So it seems to me that if there's not much RSV yet, all this exposure, all this double exposure has yet to happen. And I still don't think it quite explains the number of kids who are seriously ill. This is a testable hypothesis. If it is a double cohort effect, this is going to fade sooner rather than later. If it's immune harm, I think it's going to get worse, and we'll see kids with multiple viral infections and fungal infections too. So I think in the coming months, we'll get a better picture, and I'd love to be wrong.
All right, Dawn, I'll get your take as well.
I think this really highlights a problem with us getting data in a real-time manner in Canada. The perfect way to answer this question is if we had databases where we had records of which kids had COVID and which didn't, and we would expect that the severity would be increased in RSV if COVID was the cause, and we would expect no relationship if COVID was not the cause. But we've got two problems. One, we don't have really good databases where we can get these kind of data in real time, and two, we stopped testing. So even if we could do a database search, we don't actually know which kids had COVID or not. And I actually think I think both things are probably true. I think we're seeing a double cohort effect, and we are maybe seeing some effects of some post-COVID effects potentially. But I don't know where the balance is. It could be more of one and it could be more of the other. And I really want to make a plea for designing better health systems so we can answer these questions in real time, because it really does affect which strategy we would take.
Anthony, I'm hoping
While we're on these issues, can I just interrupt for a moment?
Sure.
I think one of the other really difficult things to interpret is that both COVID and RSV are diseases that are substantially determined by social determinants of health. So that our kids who live in poverty, whose parents are racialized, whose parents are new immigrants, have higher risks of both of them.
Let's start with a much discussed speech that Deputy Prime Minister Chrystia Freeland gave at the Brookings Institute last month, the contents of which are apparently now a doctrine. This has been dubbed the Freeland Doctrine. Here's part of the speech. Let's roll it, please.
Liberal democracy worldwide has today declined back to 1989 levels, and autocracies have been making a comeback. Many, including China, the second most powerful country in the world, have grown both wealthier and more coercive. And as Paikin is murderously proving, economic interdependence does not always prevent war. All of this means that we, the countries of the non-geographic West, need to build a new paradigm. The Cold War is still over, but so is the end of history.
Carrie Buck, let's start with you. Do you agree with her analysis?
Absolutely agree that the end of history was misguided. We expected, as part of a grand bargain in the mid-2000s, early 2000s, that somehow China and others might, by embracing new norms, starting to join WTO, et cetera, might move closer towards our system of values and support for what we call the liberal international order, and that hasn't happened. So that part I agree about entirely. In terms of what the proposed answer or solution to that is, I both agree and disagree.
Okay, hold off on that for now. We'll unpack that as we continue along. Let me get initial impressions now from Roland Paris. The Freeland Doctrine, as it's been enunciated. What say you?
Well, I also have reservations about her recommendations, but I agree with her analysis of how the world has changed. I think that the speech did a really masterful, even lyrical job of laying out how the world has changed, including the points that Carrie just made, and the very notion that economic interdependence will not necessarily lead to a more peaceful world, and that some emboldened authoritarian countries, we're talking to you, China and Russia, have been using this interdependence as a weapon to try to advance their geopolitical goals. And I think that this is something that has become clear over the last few years. A number of people have pointed this out, and this is Chrystia Freeland's version of the same assessment.
Okay. Paul, if there is now a so-called Freeland Doctrine, what are the main pillars in it?
So I would agree with what was said, that Chrystia Freeland has closed the book on the end of history, right? The idea that capitalist democracies would inevitably and irresistibly populate the globe. So she has three pillars. The first one is massively strengthened cooperation with democracies. And there you can think of the core democracies in the world, fairly easy to identify, accelerating cooperation. The second group is the most interesting. It's called an in-between group. And that one is not defined in the speech. And I think that's where the action is going to be, right? Which countries, if the third group is the autocracies or the authoritarian regimes, who are the in-between countries? Are they, is there a clear line between the democracies, the in-between countries, and the authoritarian regimes, I think is a key question.
Okay, Roland, why don't you pick up on that? Because I think, most people can see it. They know a democracy when they see it. They know an authoritarian country when they see it. These in-between countries seem to be a little murkier. What light can you shed on that?
Well, it's interesting, the part of Chrystia Freeland's speech that talked about this essentially said, well, the in-between countries can be allowed to join the alliance of democracies if they embrace our values. And then François-Philippe Champagne, another Canadian minister, was in Washington a week later, basically saying that Canada supports decoupling from authoritarian countries and from China and other countries that don't share our values. The problem with this is basically the in-between countries are the vast majority of countries in the world. It's very hard to lump them all together. We have a lot of competing imperatives in our foreign policy. And if you look at a country like Vietnam, it is not a democracy. It is a one-party state ruled by the Communist Party. It's also our biggest trade partner in Southeast Asia. It's a member of the Trans-Pacific Partnership, and it's a bulwark against the spread of Chinese influence in the region. So we have interest to be cooperating with them. It's too simple to boil it down to autocracy on one side, democracy on the other side, and then some amorphous in-between group as the rest of the world.
Okay, Carrie, let's stick with Vietnam. What category would you put them in?
I'd put them in the category of countries that we need to be able to work with. The problem is with that divide, using that divide between democracies and non-democracies as the criteria for your club, your new club, it makes it harder to reach out to the in-between countries. And the facts are that some of the major democracies right now are acting as swing states in response to Russia's war in Ukraine. So they're doing things like continuing to trade with Russia for cheap oil, They are doing things like abstaining consistently at the UN General Assembly in condemnations of Russia. And so, using democracy, non-democracy as your dividing line doesn't quite work.
Number one, last month, Norwegian military security services arrested an alleged military intelligence agent from Russia who lived for many years as an alleged Brazilian national in Canada. Number two, Canadian authorities have been alerted to the existence of 3 Chinese so-called police stations in the Greater Toronto Area in predominantly Chinese communities. Number three, last week, Global News broke a story about the Chinese consulate in Toronto funneling funds to at least 11 federal candidates during the 2019 federal election. And the last one, a few days ago, the RCMP arrested a Hydro-Quebec employee accused of sending trade secrets to China. Some recent stories plucked from the headlines. Vincent, start us off. All of this has happened in the last month. What do these stories tell us about the challenges that Canada's intelligence services are facing?
Well, the first thing that I would say is that we are basically looking at a world that is extremely, extremely turbulent. So the headlines that you've just discussed or mentioned reflect that reality, and in particular, a world where we've seen a resurgence of great power rivalry, and we have a hostile state actor like China, and it is very hostile both in its region and in other countries, flexing its muscles a little bit. And so you've seen a lot of this over the last number of years, but I think it's really been starting to pick up momentum since President Xi came to power, and I think it's becoming really a serious problem for Canada. But I would turn the question a little bit on its head just to say that I don't think it's strictly about what does it say about our intelligence agencies. I think it speaks a lot to what does it say about our perception of national security writ large, of which intelligence is an extremely important component. And I think we don't take national security particularly seriously in this country. We never have, not just this government, but previous governments and populations writ large. We tend to be very reactive. We tend to be very responsive. We're there when the chips are down, but it sometimes takes us a little bit of a while to get our act together. We've not had a national security policy in nearly 20 years, no foreign policy. So we are running a serious risk again of being on our heels and not getting ahead of the power curve with these threats that are out there, because it is a very, very dangerous world. It's not just about hostile state actors. There's all kinds of other bad stuff happening as well. So we need to up our game. We need to up it very, very soon from an intelligence perspective, but from the defense, foreign policy, development, right across the board. Okay, lots to dive into there. I think I'm going to come back to the issue of how seriously or not we take foreign policy and security issues in this country a little later on, because Wesley, we need a little more background first. Do you have a sense of how many, I don't know, call them what you want, foreign operatives or spies we have operating in this country right now?
No idea, Steve. I'm sure there's many from many countries, and this is the espionage game is of long standing. What's different about it is partly the aggressiveness of some of the key actors involved, state actors, including China and Russia, but also the tools that intelligence agencies can use when they mount their operations to steal either government secrets or secrets from the private sector, and that's certainly something that's interesting about the recent Hydro-Quebec case that you mentioned. And those tools really have taken spies into the digital world, and the phenomenon of cyber espionage, its capabilities, its ubiquity, is one of the great challenges I think that Canada and many of its allies face. So, we could play a game of trying to count the number of spies, but it'd be very difficult to count their capabilities online, which is really, really where it matters.
Okay, Besma, how about this? I gather Justin Trudeau and Xi Jinping had a 10-minute conversation at the G20 meeting in Bali, and apparently Mr. Trudeau said things like, he was, quote, seriously concerned and was pointing out to Mr. Xi about China's so-called aggressive interventions. And I wonder, in your judgment, what kind of impact can that conversation, in your view, have?
I guess, to be frank, not very much. It needs to be said. And certainly, I think, I'm going to echo what both my colleagues have noted. The threat landscape is getting worse, and China is a key actor in this challenge that we face globally, partly because I think also China's changed. We can't ignore this. This is not the same China of 5 years ago. President Xi's consolidation of power, repressiveness is really amplified now at a time that again, even Chinese Canadians barely recognize in many ways their home country. And this is really quite sad and impacting more than anybody, the Chinese Canadian community. In addition to, I think, what my colleagues noted about the international threat landscape, absolutely. China, Russia, and even some regional powers trying to really flex their muscles, thinking of Iran, Turkey, Saudi Arabia, you name it, all are playing a more active role in their regions and abroad. And part of that is because of the seductive tools that are out there. And Wesley talked about technology tools. And this is really something I think we're going to have to really recognize. So while we're really thinking about spies in terms of individuals, it's not just the individuals that's really the problem in many ways. It's the seductive tools of surveillance, seductive tools of disinformation. These are cheap, easy to deploy. And lastly, because of the domestic environment where, we had enormous amount of polarization in this country, in many democracies, the rise of populist nationalists, which have been, really effectively dividing us. Many of these international threat actors now have an entryway. They have a way to penetrate our societies, to divide us from within. And that's what they're doing. It's a far easier and cheaper tool than trying to cultivate a spy to sort of, pretend to be Canadian or pretend to be, Brazilian in this case of the Norwegian case, and then studying here in Canada. That's going to become rarer and rarer. What we're going to see is more digital surveillance, more AI tools, more all of those emerging technologies being weaponized. And frankly, unfortunately, that polarization from within is just going to make it a lot easier to penetrate.
So what makes memories stick?
Yeah, that's an excellent question. And I think it's related to what everyone has mentioned so far, and Dr. Russell in particular. The one thing that I think is really interesting, and what you're pointing at, is this importance of meaning. So sometimes some of our experiences are meaningful to us. They connect to other things that we know, or maybe they're important to our notion of who we are. And I think these kinds of memories are the ones that tend to stick. And why they stick might be because we combine our memories for certain experiences that happen in our lives with everything else that we know, our prior knowledge. So if we can contextualize a given piece of information and connect it to other things that have happened in our lives, that piece of information is better situated and better connected to other pieces of information in our lives, and we are consequently better able to remember it. So in my lab, what I'm really interested in looking at is what is this meaningfulness that seems to drive our memory system, and can we better define what that is as psychologists to, unpack how the brain supports and interacts with meaningfulness in relationship to remembering specific recent events?
That is a great question. Rosette, have you got an answer for that?
Actually, I'll ask Bedica how he is defining meaning and whether you can take apart meaning from just more experience. So is it just that there's more experiences related to what you're experiencing and then it has more connections to embed with, or is there something special about the meaningfulness, something with the amygdala or something with the orbitofrontal cortex? Do you think that there's something particular about meaning I'd like to ask?
Yeah. Sure. So in terms of what I think it's not only the number of connections, because we have tons of experiences in our lives, walking down a hallway where we might have done that tons and tons of times, but it's not really that substantial. It's not really that important. It doesn't really actually connect to other things that are important to our lives. So I think there are certain features of our experience that might be more connected to things like our self and things like the aspects of our past experience that we personally consider important, whatever those may be. And I think those ones might be overrepresented and more able to kind of be subsequently remembered. And yeah, that's what I would say. So I wouldn't say it's all equal.
Signe, does that ring true for you?
I definitely agree with that. That we memories that are more meaningful are ones that are going to stick more. My thoughts are also trying to disentangle meaning from emotion, because we do know that powerful effect that emotion can have on us encoding and storing memories, and those memories really become central features. This is because of a region of the brain called the amygdala. the amygdala is very interconnected to some of these sensory processing regions that we've been talking about. So when you have an emotional event,
I'm going to ask our director to bring the picture up again so you can speak to it, because we got pictures for everything here.
Okay,
so
great.
let's see the brain again. Okay, there's the for those listening on podcast, the amygdala is over there on the left. In the middle, but labeled on the left.
Yeah, so it's just kind of like dipsy doodle down from the hippocampus. So when you have an emotional experience, the amygdala will actually send messages to some of these sensory perceptual processing regions of the brain to engage those processes. So you really pay attention to your environment, and subsequently you're going to encode that experience more than a non-emotional event. So emotion is something that is intricately tied to meaning. And, that's something that was just on my mind as this conversation was unfolding between Vidika and Rosanna, is whether we can disentangle those effects.
Well, let me see if I can complicate things a little bit more here. Charlotte, I gather there are different types of memories that stick with people, semantic and episodic. What's the difference?
I think, so in the main, a lot of what we've been talking about are episodic memories, so memories for events that we have experienced, unique events throughout our life. So remembering having dinner last night, remembering our holiday last year, or even just remembering, well, it's after lunch for me, but walking down to get lunch just before this. All of these are episodic memories, whereas semantic memories are memories for facts that we've learned, general knowledge, things like that, but also personally related facts, so personal semantics, so the names of our best friends when we were young, or the knowledge of where something is in our local town. So these semantic memories are not for events. They don't have the same contextual information that we've been talking about a lot associated with these event memories, where we need to remember not just what happened, but where it was, when it was, tag it temporally in terms of our life timeline as well.
In this book, I gather the evidence linking trauma, for example, and adult illness, both of mind and body, whether we're talking about chronic physical illness. For example, a Canadian study showed that men who were sexually abused in childhood have triple the risk of heart attacks as adults. And the same statistics can be shown about trauma and addiction, trauma and mental health. A British psychologist, a member of the British Academy, Dr. Richard Bentall, said that the link between childhood trauma and adult mental health illness is as strongly proven scientifically as the link between cigarette smoking and lung cancer. But Steve, the average medical student in Canada, shocking to say, doesn't receive a single lecture on trauma and its connection to adult illness. Unbelievable. Given the tens of thousands of research papers, I cite some of them in the book, linking trauma and all manner of conditions of body and mind, the average medical student doesn't get a single lecture about it.
Why not?
It's almost unfathomable. Why not? Because the Western medicine, again, for all its incredible achievements, and I'm certainly, as trained in Western medicine, I can only marvel at the amazing accomplishments of my profession. But at the same time, it makes the mistake of separating mind from the body. So it doesn't understand that people's emotional lives and therefore their social lives are actually connected to their physiology. This is despite the fact that great physicians throughout history have recognized these links. Canada's own Sir William Osler said in 1890 that rheumatoid arthritis is a stress-driven disease. Since he's made that comment, there's been so much research proving the accuracy of his observation. The average rheumatologist doesn't know a thing about that research because we separate the mind from the body. So when you go to a neurologist or a rheumatologist or any kind of a specialist, they'll never ask you about trauma, stress, your personal relationships, even though physiologically these are all connected to what's happening to the biology of your body.
Well, you do make a distinction between, let's call it uppercase T trauma and lowercase t trauma. Yeah. What's the difference?
Well, it's only to distinguish the events that cause the trauma. And the trauma itself means a wound. So people can be wounded in a number of ways. Trauma is a psychic wound that leaves an impact in the body, in the nervous system, in the brain. And those imprints show up in the form of dysfunctions, anxieties, depressions, physical illness, and so on later on in life, as voluminous research has beyond the shadow of a doubt demonstrated. In terms of what causes trauma, it can be two types. It can be the big T, which is the easily identifiable terrible things that do happen to children, such as physical abuse, sexual abuse, emotional abuse. Look at the indigenous population and its experience in the residential schools, for example, and the outcomes of that in mental health and suicide and addictions and physical illness. So those are the big T ones, you know, or a war, a tsunami, the death of a parent, violence in the family, a parent dying, a parent being jailed. These are what we call the big T traumas. But kids can also be wounded, not because terrible things happen to them, but because the right things that should happen don't happen. In other words, if children's needs are not met, and children have certain definable evolutionary dictated emotional needs for healthy development. If those needs are not met, as they're not in this society, children can be wounded. And those developmental events is what I call small T trauma. For example, you can hit a child and beat them and the effects are predictable. You can spank them, as some psychologists, some very well-known psychologists in Canada still advocate, despite all the evidence that spanking is as harmful as a more severe form of physical abuse. Or you can just not pick a small child up when they're crying and they need your attention. They need the physical contact.
That's just some of what we covered this week. You can find more, including the full conversations, on our website, TVO.org, our YouTube channel at youtube.com/theagenda, or our Twitter feed, twitter.com/theagenda. And that's it for this Friday, November 18th, 2022. Monday, Steve talks to author Anand Giridharadas about his new book on how to get polarized people to talk to and perhaps actually hear each other. I'm Nam Kiwanuka. Thanks for watching TVO and for joining us online at TVO.org. Have a great weekend, and Steve will see you on Monday.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.